Good morning, dear colleagues. This is Dr. Norah A Alqarni, Family Medicine Senior Registrar. It's my pleasure to be with you today. I pre-record this lecture because of my very busy schedule in the clinic. So today I'm going to talk about hyperuricemia, non-symptomatic. Actually, this study done at 2018-19, and I will present the result for you. Knowledge and practice in management of asymptomatic hyperuricemia among primary healthcare physicians in Western Saudi Arabia. We will go through the background, rationale, aim and objectives, method, result, and discussion and conclusion. First of all, what we mean by asymptomatic hyperuricemia: serum uric acid level more than 6 milligrams per deciliter and without specific symptoms like renal stone or joint inflammation. Epidemiology, more prevalent in men, and it's correlated positively with age and weight gain in both sexes. The pathophysiology of hyperuricemia either increased production of uric acid or decreased renal excretion of uric acid. Asymptomatic hyperuricemia is associated with the higher risk of hypertension, chronic kidney disease, coronary artery disease, and insulin resistance syndrome and diabetes. Rationale: lack of constitutional division and management of asymptomatic hyperuricemia. Guideline exists for acute and recurrent gout, like American College of Rheumatology and American College of Physicians. Why we treat hyperuricemia if it is asymptomatic? We treat it to prevent progression to gout or other complications like renal stone and crystals. And this is still controversial in a lot of literature. Now I will go through the aim and objective of this study to assess current knowledge and the practice level in asymptomatic hyperuricemia among the primary health care physician in Saudi Arabia, and to investigate the factor and the predictor of misprescribing the urate lowering treatment, and to explore perceived barrier to management of hyperuricemia. The method of the study the design was a cross-sectional study. It was the period time from 2019 until 2018. It was in Ministry of Health. Sampling, it's two-stage stratified sampling and data collection semi-structured questionnaire. The study questionnaire cover many dimensions like demographic and professional data like age and gender, a specialty of the physician, year of practice, and average number of patients seen per day. And the second dimension is perception about hyperuricemia, like definition, correlation with gout, and awareness about the major causes. Then the knowledge about asymptomatic hyperuricemia, level of practice, and perceived barrier to management of hyperuricemia. The design of the study and validation developed based on American College of Rheumatology and American College of Physicians guidelines. It was phase and content validity by 2 rheumatologists and 1 epidemiologist, and pilot is tested among 20 eligible participants to assess the clarity. In the result, participant characteristic, it was 66.2 of the participant was female. We covered the year of practice and specialty. 47 of physician was family medicine doctors, and 41 of the years of practice was up to 5 years. The other dimension for professional characteristic was number of patients seen by day, and patients have gout on urate lowering treatments. So number of patients seen by day, 45 of physicians seen up to 20 patients per day. and patient having gout or on medication was 56%. Okay, the result of this study was in the internal consistency of the questionnaire was knowledge, practice, and perception about asymptomatic hyperuricemia. Question one was, in your opinion, asymptomatic hyperuricemia and gout represent different related diagnoses, and this is the true answer. It was 64.7% of physicians have this answer. According to your knowledge, what is the best definition of asymptomatic hyperuricemia? Elevation of serum urate level without gout symptoms. And 84.6% of physicians have this answer, which is right. According to your knowledge, what are the possible mechanism of hyperuricemia? Increase urate, as we mentioned in the first two slides, this is the mechanism of hyperuricemia. Increase urate production and decrease renal excretion of urate. Increase production combined with decreased excretion. And 71% of physicians answer increase urate production. The overall knowledge, the main score was 18, and the cutoff 20, and the adequacy rate was 32.8. Now, through the result, we will go through prescribing pattern in asymptomatic hyperuricemia. 88.1% of physicians prescribe low purine diet and lifestyle recommendation, which is the right recommendation. Majority of participants, like 88.1%, would recommend a low purine diet and lifestyle change to patients with asymptomatic hyperuricemia, while 27.4% would prescribe short-term urate lowering treatment, and 21.9% would prescribe long-term urate lowering treatment. So it's not small number that 21.9% of physicians prescribe long-term treatment without symptoms. Barrier to practice, and this is very important slide. Lack of knowledge about the guideline. This is one of the very important factor in the barrier to practice. One of the important factor was lack of the knowledge about the guideline. The next was unawareness about the existing guidelines. The third one, inadequate knowledge about the disease. So lack of knowledge about the guideline was the most frequently reported barrier to adequate practice in asymptomatic hyperuricemia, followed by lack of awareness of the guideline, existent and inadequate knowledge about the disease. Demographic, this is a demographic factor associated with the urate lowering treatment misuse. I will move for the next. Here we will go through the other factor, year of practice. 47.3 was the high percent that mispractice increase for physicians between 10 to 15 years work, maybe because they are not updated about the new guidelines. And specialty was 69.2 about other specialty. Okay, the summary and finding, low knowledge level about asymptomatic hyperuricemia. Only 1/2 of the participant physicians were able to correctly define asymptomatic hyperuricemia as elevation of serum urate level without presence of gout symptoms. Poor to moderate knowledge about hyperuricemia, and notably factor mechanism underlying hyperuricemia. Inadequate practice. Less than half of physicians achieve adequate history taking, physical examination, and comorbidity evaluation in patients with asymptomatic hyperuricemia, like important to rule out differential diagnosis such as arthritis, nephrolithiasis, and undiagnosed gout attack, subclinical arthritis, or urolithiasis. Screen for family history of gout, genetic background. Rule out external cause of hyperuricemia, like urate elevating medication, As we know, there is some medication cause high uric acid. High rate of urate lowering treatment misuse, almost half of the physician. In Saudi Arabia, and this is previous study done by other doctor in 2014, Dr. Mustafa, he reported that 84 of physician would recommend allopurinol treatment for asymptomatic hyperuricemia. And this is high level of misprescribing than seen here. That means they improve, the doctors improve from 2014 until the current time of the study. Allopurinol prescribing for asymptomatic hyperuricemia is a frequent practice among UK physicians as well. Frequency associated with the lack of screening for medication interaction and inadequate follow-up, risk of severe side effect and complication. The clinical relevance of asymptomatic hyperuricemia and whether it should be treated have long been controversial. Nevertheless, physicians should be aware of hyperuricemia management and practice. According to American College of Rheumatology and American College of Physicians guideline, the sole therapeutic option warranted for this asymptomatic high uric acid are low purine diet and lifestyle change and modification. Limiting intake of high purine food, controlling obesity, smoking cessation, and alcohol consumption, and very important to reduce health risk associated with hyperuricemia. Other findings suggested high prevalence of hyperuricemia and gout among patients visiting primary health care. Few epidemiological study in Saudi Arabia, Dr. Al-Arfaj estimated that prevalence of hyperuricemia was 8.4. Prevalence increased all over the world with increase in obesity and disease associated with poor life and dietary habit. Two paradoxical association. Attendance to rheumatology conference associated with higher risk of urate lowering therapy misuse. Physicians have gap in rheumatology being more interested in related conference. We don't know. This was something, it was for me, something, no justification for this, but this is the finding in this study. Having a close relative with hyperuricemia predictive for higher risk of urate lowering treatment misuse. Unfortunately, for both issues, the questionnaire does not include sufficient details to explain these inconsistencies. In conclusion and recommendation, there is a major gap in knowledge and practice. There is major gap in knowledge and practice regarding asymptomatic hyperuricemia among physicians in Western of Saudi Arabia. Prescribing practice with high rate of urate lowering treatment misuse, lack of awareness and knowledge about international guideline, and inadequate knowledge about the disease were primary reason for low confidence and practice. So lack of knowledge about the guideline and lack of knowledge about the disease itself, it's one of the primary reasons for misprescribing. These observations suggest the importance of the important gap in formal training in hyperuricemia or rheumatology specialty, emphasizing the need for strength theoretical and clinical training, and to reduce the risk of malpractice associated with morbidity and resulting cost. Here are the references. Thank you, and it's my pleasure again to be with you. I hope to see you soon without virtual lecture. Thank you.